تخص الدكتورة إيثار اللي هي نيورولوجي ريزيدنت السنة الأخيرة عندنا في القسم، والدكتور عمر طبعا جبارة اللي هو فاينل يير نيوروسيرجري ريزيدنت، وطبعا الطلاب ما شاء الله عنهم يعني كثير مبسوطين فيهم. واهلا وسهلا فيكم جميعا. الاكسبيرينس تبعتي بالنيورولوجي ريسيرش بصراحه راح تكون اكثر يعني اعبر عنها من خلال مراحل بحياتي واشخاص مروا او مريت عليهم بحياتي وتعلمت منهم. والهدف النهائي من هذا التوك البسيط اني اجاوب 4 اسئله، انه واي ريسيرش هو السؤال الاول، يعني ليش نحن بنعمل ريسيرش؟ بعدين وات ريسيرش، شو ريسيرش بنعمله؟ بعدين وين ريسيرش، متى بنبلش نعمله ومتى؟ وبعدين هاو ريسيرش، كيف نعمل؟ هذول 4 اسئله رح اجاوب عليهم من خلال التوك تبعي. اول مرحله بال 2005 لما انا كنت ميديكال ستودنت هون في جامعه العلوم، كنت طالب طب سنه خامسه، بسنه خامسه بتهدى الامور شويه عن سنه رابعه. بلش الواحد يفكر باشياء اخرى. انا مشغلها بصف ال11 تقريبا يعني ماشي. فانا حكيت انا يعني حابب اني اعمل ريسيرش، حابب اعمل ريسيرش لانه الريسيرش يعني هو اكيد الوجه الاجمل للطب، الشيء اللي بيخليك تتعرف على الاشياء وتتعلم الاشياء هو حقيقه العلم، يعني العلم هو ريسيرش، يعني كل اللي تعلمناه بالكتب موجود بالكتب هو عباره عن نتاج للريسيرش، ما في معلومه بتقراها غير هي نتيجه دراسه، نتيجه علم معين اخذ منحى الريسيرش. فلما صرت بدي اشوف حدا اشتغل معه خطر بالي الدكتور بشير خصامنا. الدكتور بشير كان اسيستنت بروفيسور وكان مبين انه نشيط، غير انه يعني لما تحضر محاضرات وتلف معه بالراوند يعني في ناس هيك بتحس انه انا هذا الشخص بدي اتواصل معه. فيعني I looked up to him وعارف انه نشيط، فرحت عليه ودقيت على الباب، دخلت عنده قلت له دكتور انا بشتغل ريسيرش. قال لي شو بدك تشتغل؟ قلت له ما عنديش فكره بدي اشتغل معك. فقال لي طيب بس انا مشغول، طبعا كل الكلينيشنز مشغولين. والله اشتغلنا في شيء على السليب ابنيا مع الاتريال فيبريليشن، مش عارف بس هي انشغلت وكذا. بجوز نعمل شيء على السليب ابنيا مع الاسكيميك هارت ديزيز او شيء ثاني ما بعرف، يعني حكى لي كلمتين هيك وخلص بعدين ورحت. المهم رحت بعدين رديت رجعت له ثاني يوم ثالث يوم قلت له دكتور اشتغل لازم انت بدك تساعدني وبضطرك ترجع علي. قلت له دكتور انا بدي اشتغل، بدي اتعلم منك، بدي اشتغل معك وبدي انتج، يعني ما فيها انا كلهم حكوا لي بشير خصامي، انا بروح بشير خصامي. المهم هاي الشغله تعلمتها منه انه هو بيستقبل طالب ما عنده باك جراوند تمام وبيعلمه بيشتغل معه وبدخل في حوار مرات كثير بسيط، يعني في عنده قابليه انه يتعامل معك كزميل يعني اوكي. كنا نقعد في المكتب كنا ناكل بسكوت، دائما كان عندي بسكوت في المكتب كنا نصلي مع بعض ماشي، وكنا نقضي وقت كويس مع بعض واتعلم منه كثير، تعلمت منه شغلات، تعلمت منه كيف بفكر، كيف بيحول الستاتستكس لكلينيكال مينينج، هاي كثير تعلمتها منه ماشي. تعلمت منه بعض المفاهيم بالستاتستكس وبعض المفاهيم بالاحصاء الحيوي، تعلمت منه كيف يعني ممكن انت ما تكونش ستاتستيشن حتى تكون جود ريسيرشر، بس تكون ايش؟ عندك فيجن، يعني تطلع انه انا كيف بقدر هاي الفكره احولها لرساله، او شو بدي من هذا البحث، او شو انشغل وشو في شيء بدي اضيفه، او كيف الطريقه اللي بدي اخرج فيها النتيجه. هاي يعني فنان هو فيها، كيف انه بده يوصل البيبر او يوصل الرساله او يوصلها بطريقه تكون كويسه. طبعا بعدين هلا بلش الشغل، دخلنا في الجو. طبعا هذا توفيق رب العالمين انه الله يحط واحد زي الدكتور بشير خصامي في طريقك ويساعدك ويدفشك وهيك، هذا يعني مش الكل صح له هيك. بعدين اللي صار انه صار في اعلان على مؤتمر في اربد للنقابه، وكان في طلبوا ابستراكتس، فناداني قال لي تعال ابو ياسين. طبعا بالاول ما كانش يعرف انه انا ابو ياسين، كان يناديني ابو سليب لانه احنا ثلاث تبعنا على سليف ومش عارف اسمي اول كم من لقاء، بس يشوفني يا ابو سليف تعال. فالمهم ناداني قال لي شو رايك نقدم الابستراكت؟ قلت له ماشي. قال لي بس اسمع انت بتعمل البرزنتيشن which is good، هي شيء رائع. قلت له ماشي دكتور ابراهيم. قدمناها انقبلت. رحنا على المؤتمر النقابه في اربد وكان هو من الحضور وعملت اورال برزنتيشن كان ممتاز. ماشي. بعد هيك استمرينا في البحث. طبعا البحث كان انه انا بدي اطلع اوقف على باب الكاث والمرضى اللي داخلين اعمل لهم سيرفي للسليب ابنيا وبس يخلصوا استنى ابقى يخلص. ماشي. وبعدين اكتب نتيجه الكاث. اوكي؟ لانه احنا بنقارن السليب ابنيا مع الاسكيميك هارت ديزيز. سليب ابنيا باي ذا كويشنير والاسكيميك هارت ديزيز نتائجه باي كاث، ونشوف هل السليب ابنيا كل ما زادت بتكون الستينوسس اسوء او الديزيز اسوء. اوكي؟ فكنت مبسط هناك معي وراد وقاعد. تمام؟ بعد هيك صار في بالكرك مؤتمر نقابه على مستوى الاردن، برضه حكى لي روح قدم. كانت الاستدي كبرت طبعا، كل بوبيوليشن جمعت اكثر وطلعت بنتائج احسن. ورحت وعملت اورال برزنتيشن وكان ممتاز. وذكر متى كان الدكتور خالد عبدالله موجود واجى وسلم علي ودعمني، يعني حكى لي كلام كويس. ودكتور نذير عبدات كان متى كان موجود وحكى لي انه الدكتور بشير انت بتشتغل معه، الدكتور بشير زميلنا وكذا الى اخره. فكان كلام حلو، تجربه حلوه، قدوه، صح؟ يعني هي الفكره بالريسيرش انه كل خطوه تخطك اللي بعديها. هسه بعد هيك استمرينا بالعمل والبحث والى اخره. اجت في لحظه قويه اللي هي طلبوا من لنداو ميتينج، اذا حدا سمع فيه نوبل لوريتس لنداو ميتينج في المانيا، طلبوا طلاب من الجامعه انه حدا يقدم ينافس على هذا المؤتمر، انه يطلع عليه. مؤتمر باختصار بيجي عندك 20 واحد فائزين بجائزة نوبل في الطب وبيحضروا يونج ريسيرشرز من كل العالم معاهم لمدة أسبوع، بيسمعوا منهم، بيلتقوا فيهم، بيعملوا انتراكشن معهم. فكانت أول مرة بيعملوا دعوة للأردن. اوكي؟ فكان مطلوب واحد يمثل الفاكولتي، واحد يمثل الستودنتس الميديكال ستودنتس، وواحد يمثل الماستر. فكان الدكتور بشير أيامها مش عارف هو مساعد عميد او مش عارف نائب عن مساعد عميد. فالدكتور عبد الفتاح الحاضر كان العميد، اجى عليه قال له يا اخي في عندك طالب في هاي المواصفات. شو المواصفات؟ بيكون 10% بالعلامه، جود سي في وريسيرشر، يعني عامل ريسيرش. فالدكتور بشير مين تذكر اتصل فيه وناداني قال تعال قال اسمع جيب اللي معك هذا، في شاب معك اشتغل اخر فتره جيبه معك. مين الشاب هذا اللي معي؟ كان الاول على الدفعه وصاحبي وصديقي اللزم يعني، بس هو علامته اعلى يعني هو على الدفعه. فانا قلت له ماشي. فرحنا على العماده وبعدين صاروا يحكوا اوكي مين احمد ياسين؟ قلت لهم انا. قالوا الدكتور بشير حكى عنك اشتغلت معه ريسيرش صار لك سنتين او هيك شيء. قلت لهم قال طب مين انت؟ هذاك احمد اللحام، احمد حسني اللحام. طيب انت شو علامتك؟ انا كان معدلي 86 شيء زي هيك 87. وانت شو علامتك؟ 91 ونص 92. فالمهم العميد لف هيك بطل يطلع علي طلع عليه. فحكوا طيب انتوا شو يعني انتوا اثنين احنا بدنا واحد منكم كذا. فنط احمد قال الدكتور بصراحه هو احمد ياسين يستحق انه يطلع علي، هو اللي اشتغل بالريسيرش، انا اشتغلت معه بس شهر. اوكي؟ بعدين المحيطين بالدكتور عبد الفتاح قالوا احنا هذا مؤتمر ريسيرش، احنا يعني بدنا الريسيرش والزلمه كمان توب 10% يعني مش انه برضه هين يعني، فبدنا الريسيرشر. اوكي؟ فاخذوا. تمام؟ طبعا اخذوني قدمت، طلعت النتائج بعد 6 شهور. هذا كومبيتيشن كانت على مستوى العالم. اخذوا من حوالي 3000 او 5000 ابليكانت، اخذوا 600 واحد. فطلع لي. تمام؟ هلا الفكره بدي اوصل لك اياها انه اخذوا مين؟ الريسيرش. لانه هذاك الاول بس اخذوا مين؟ اللي عنده ريسيرش اكسبيرينس. تمام؟ طيب فهي كانت كثير قويه. طلع كيف انت التراكمات تاخذ تعمل ريسيرش ابستراكت، دكتور كويس منتور منيح بقدمك، بتروح برزنتيشن، مؤتمر ثاني برزنتيشن، بيرشحك لمشوار جائزه كونفرنس وات ايفر، تطلع تتعرف على ناس. هناك تعرفت على مين؟ أخذ السنة وبلش لسه مرحلة جديدة. أنا هو طلع برضه على نفس المؤتمر، التقينا هناك تعرفنا على بعض، وهناك بلشنا مرحلة جديدة. اوكي؟ من نيورولوجي من هناك بلشت الرحلة. الآن بدي أنتقل مباشرة على الريزيدنسي. اوكي؟ بأمريكا. بالريزيدنسي في أمريكا طبعا مفهوم الريسيرش خلص توثق عندي إنه مهم. مفهوم الريسيرش إنه بقدمك، مفهوم الريسيرش إنه بعطيك فرص. واضح يعني من الهيستوري إنه اللي صار معي إنه بعطيني فرص أطلع على الستيج، أطلع على المؤتمرات، أقدم إشي، أتواصل مع الدكاترة. مزبوط؟ فلما رحت على أمريكا مفهوم الريسيرش قوي في بالي. سنة أولى بكون باطني قبل ما تدخل أعصاب. في سنة الباطني أنا طبعا بدي أساوي إشي، متحمس يعني. فمر علينا كيس كانت نيورو ميديسن، يعني هي هيمي كوريا ان دي كي اي، فيها نيورو فيها ميديسن. فأنا شو سويت؟ يعني اقتنصت الفرصة وجمعت بين الميديسن تيم والنيورو تيم باك اند فورث. كنت لساتني مش مع النيورو، واشتغلناها كتبناها از ابستراكت بالبدايه. كان في مؤتمر الامريكان ميديكال اسوسيشن، يعني اكبر شيء في امريكا اللي هي الامريكان ميديكال اسوسيشن، كان في هاواي. فانا كتبت ابستراكت. وهاي نقطه مهمه، انه اي مشروع بدك اياه يمشي ويتوثق اول مرحله تكتب ابستراكت. لاقي لك كونفرنس قدم فيه، لانه هاي اول مرحله بالببليكيشن بتاخذ شكل كويس، بتصير انت حاسس انها لها فورم بدل ما تكون كلام. والابستراكت ما بتاخذش منك وقت كثير، بس بيكون عندك زي بريليمينري ريزلتس اللي تحطها بشكل ابستراكت. مش مطلوب منك تيبلز ولا فيجرز ولا شيء، يعني بتغلبش كثير. المهم حكينا بدنا نقدم على المؤتمر هذا. حتى الدكتوره اللي كانت معي كانت يعني سوبر اوبسيسيف بالكتابه، يعني كانت دمار في النوتس يعني دائما انه انت مظبط قديش تحط لك 60%، هيك مظبط النوت تبعتك. فقالت لي طيب، قلت لها صداي للأربعة العصر عشان نقدم للمؤتمر، بعدين بتروح الفرصة. قلت طيب ماشي، خليني بالعيادة، بعد العيادة بشوفها مش عارف ايش. صارت الساعة 4 إلا دقيقة وهي لساتها بتجاوبش على التليفون. قلت والله قدمها. المهم رحت قدمت. تمام؟ بعد ما خلصت العيادة كان الساعة 4:30 5، اجت علي ليش قدمتها وكذا، فرجيتها اياها وقالت لي مش راح يقبلوها، كتابتها مش كويسة ومش عارف ايش. قلت لها يا دكتور يعني أنا خلص، يعني يا انه قدمنا يا انه ما راح نقدم للأربعة يعني، واحنا اتفقنا من امبارح وانت تاخرتي يعني. المهم راحت الموضوع. بعد 2-3 بيجي ايش؟ اكسبتنس للابستراكت. تمام؟ بس شوفوا في عنصر حظ في الحياه، يعني في هيك طبعا بركه رب العالمين، يعني ما بديش اسميها حظ. طيب ماشي، انقبلت بدنا نروح نقدمها بهواي. هواي هونولولو كان جميل جدا. المهم طلعنا هواي، رحت عملنا البوستر، وكان في بدك تعمل برزنتيشن بالبوستر، جنب البوستر وفي لجان بدها تقيم كل البوسترز. كان في 300 بوستر. فانا استعديت لما بقدم البوستر، استعديت كويس. وهي كمان مسج، لا تاخذ الامور لايتلي، بدك تعمل تنجز، حتى لو المهم بالنسبه لك يعني لها حجم معين اتقنها. وانا استعديت كويس للبرزنتيشن، كويس يعني. فاجوا اللجنه وهذا، وعملت برزنتيشن ممتاز جدا. اوكي، وراحت اللجنه. ثاني يوم بقولوا ايش؟ مش عارف انهم بدهم يهنوا البرزنترز واللي اجوا من 300 ابستراكت. فجيت انا زي هيك، فحاطين هيك بوفيه جانبي، وانا قاعد باخذ الاكل مش عارف ايش، اللي هم بيحكوا عن ياسين فيرست بليس اوسكار برزنتيشن. انا ما صدقت، عن جد ما صدقتش حالي ولا كنت اتوقعها. فاخذت الجائزه ماشي، فيرست بليس بالامريكان ميديكال اسوسيشن بال 2012 على بيست بوستر. اوكي، رجعنا على مين؟ على هذيك اللي كانت ايش؟ اللي مش راح يقبلوها. فتوزع يعني بيج وين. طبعا كانوا معطيني مصاري عشان اروح، رضوا اعطوني كمان مصاري جماعه البيوتي يعني. هناك طبعا صار في قفزه نفسيه، قفزه في القسم، وهذا يعني الزلمه بجيب ماشي. فانا برضه انطلقت من هون. اهم شغله كل ما تطلع درجه تدخل بنفسيه جديده عشان تنجز انجاز جديد ماشي. بلشت هون اشتغل على، دخلت في القسم النيورولوجي، بلشت اشتغل على الابحاث النيورولوجي. بلشت انا اتحشر في الناس، يعني انا ادخل في الدكتور، شو رايك نعمل هاي الكيس، شو رايك نعمل هاي الاستدي. بعدين شو فوق نشيط شو بصير؟ what goes around comes around. اوكي زي الكهرباء هاي لما بتشتغل بصير الناس يعرفوا انك بتشتغل فبيجوا عليك بتصير تشتغل اكثر وهكذا. فصار في ابحاث مستمره، واهم شيء زي ما حكيت لكم تنطلق الفكره من الفكره لتشتغل عليها تطلع ابستراكت، بعد ابستراكت بيبر وهكذا. بعدين رحت على ام دي اندرسون. ام دي اندرسون سنه ثالثه عملنا سنه فيها كانسر سنتر في النيورولوجي ديبارتمنت، هناك كان هذا جزء من الريزدنس تبعنا، وكثير هم نشطين بالريسيرش، وهناك اشتغلنا كويس. كان في دكتور اشتغلت معه لحد الان بدنا نشتغل معه. اوكي هاي كمان شغله، لا تضيع علاقاتك، يعني العلاقه القديمه ابني عليها. انا اليوم بشتغل مع الدكتور بشير، مع الدكتور خالد، ومع الدكاتره النيورولوجي اليو تي ام بي ودكاتره ام دي اندرسون. ما تضيع علاقاتك في الريسيرش، بالعكس ضيف. تمام؟ اشتغلنا شغل كويس. بعدين طبعا قدم على المؤتمرات، قدمت على المؤتمرات، فزت كمان كم من جائزه بنفس الطريقه. ابستراكت بوستر ممتاز كويس، فوز جائزه، سكند بليس، ثيرد بليس، مش عارف ايش زي هيك. مثلا قدم على الكونفرنس في جائزه مثلا عشان الريزيدنت سكولرشيب بقدم لها. تمام؟ كمان يعني هاي كمان مسج بخليك نشيط في موضوع الريسيرش وما يتعلق به، يعني مؤتمر بتعلق بالريسيرش خليك نشيط فيه. في جائزه لبست ابستراكت قدم لها. في مؤتمر روح احضر وشارك واعمل علاقات. اوكي؟ خلصنا رحنا على الفيلوشيب، رحت على اليو بي اف سي. This is even a bigger center. كثير ريسيرش شغل، اشتغلنا معهم، تعرفت على منتورز اكبر، اشتغلت معاهم وقدمت ابستراكت وفزت بشغلات، واشتغلنا على بيبرز. وبس رجعت على الاردن ضليت اشتغل على بيبرز معهم وطلعنا البيبرز. بس شيء طريف بسيط يعني، لما رجعت على الاردن البيبر اللي بلشت معها مع الدكتور بشير بال 2005، وطبعا كنت ازن عليه طول الوقت يلا بدنا ننشرها يلا عشان اسجل شيء باسمي يعني. وهو يا احمد يا زلمه اتركني شوي انا مش فاضي، انا كذا، انا خلص مش انت عملت منها ابستراكت، مش انت عملتها منها كذا، خلص يعني استفدت. المهم بس رجعت ولو شو بيقول لي بعث لي بيقول لي كيف اسمك الرسمي هيك؟ اقول له ليش؟ قال لي نشر البيبر الهديك اياها يعني ب 2005 ماشي 2017. بس استفدت منها لانها نزلت معي هسه بالبروموشن بقدر استخدمها يعني. بعد هيك هسه هون مرحله جديده اللي هي بالجامعه. هاي المرحله يعني بتذكر كلمتين لاثنين، الدكتور باردوج كان معي هو التشير اوف ديبارتمنت اوف نيورولوجي في يو تي ام بي، حكى لي شيء، حكى لي the first 5 years of your career in academia you should work day and night على research so that papers come out of all your orifices. يعني بدك تنتج بيبرز بالهبل. طبعا هون كان برضه بيقابلها كلمه للدكتور خالد السالم، قال لي ورك بارلل، ما تشتغل على مشروع ثم مشروع، لا اشتغل مشاريع مع بعض. وهون بيجي كلمه للدكتوره رنا عبيدات، وين بنتها؟ بنتي حكت لي you have always to have pipeline. بيكون في عندك ريسيرش مرحله الفكره، ريسيرش مرحله البروبوزل، ريسيرش مرحله الداتا كولكشن، ريسيرش مرحله الستاتستكس، ريسيرش مرحله الرايتنج، وريسيرش مرحله السبمشن، وريسيرش مرحله الريفيجن او الريسبونس تو ريفيورز. فحكت لي هاي، حكت لي لازم هذا البايب دائما شغال عندك. اوكي؟ الشيء الثاني اللي سويته ويعني لقيته مثمر انك تتعاون مع الاقسام الثانيه. يعني ما تشتغل بس مع قسمك، اول شيء اشتغل مع قسمك، مع كل الفاكولتي اللي معك، الممبرز، الكوليجز، بعدين اشتغل مع الاقسام الثانيه في الكلينيكال والبيسك عشان يطلع ريسيرش كويس. بعدين ما تضل تتصدر كل شيء، يعني بدك تكون في سؤال على كل شيء، بزبطش، ما في وقت ومش حلوه يعني، بدك كمان تكون متعاون. رسائل للطلاب انه من اهم الشغلات انه بس تتعامل مع منتور ما تفكر حالك اشتغلت اكثر منه، شو ما كان شغلك ضل اذا هو صاحب الفكره وصاحب الديزاين، هي اهم شغله. انا لو عملت داتا كولكشن ماشي على راسي تعبت انت، بس الكواليتي اوف وورك هو بيكون في الانيشيشن او الجنريشن اوف ذا ايديا، والستدي كونسبت، والستدي ديزاين، والاخراج النهائي اللي هو على شكل انه الاندرستاندينج اوف ذا ريزلتس، كيف تحولها وتعملها انتربريتيشن، والرايتنج اوف ذا مانuscript. فالطلاب بدهم مرات بحس طلاب يكون يعني عامل له كيس ريبورت وجاي وفكر إنه يعني بيعرف كثير، فديروا بالكم من هاي الناحية. الشغلة الثانية إنه يكون نشيط، يكون persistent، وبنفس الوقت يكون متواضع واعترف بالفضل للناس اللي ساعدوه، ويكون نشيط. وأنا بحكي، أنا جملتي إنه الريسيرش في المستقبل رح يكون أساس لنجاح الطبيب. الطبيب العادي اللي بده يشتغل طب عادي إذا ما بيعرف بالريسيرش ما رح ينجح. فالله يوفقكم وثانك يو سو ماتش. الآن دكتورة سماح أبو رحمة راح تحكي لنا على الجينيتيك دايجنوستكس إن نيورولوجي.
صباح الخير للجميع، أهلا وسهلا فيكم في مؤتمر نيوروبيديا. Next speaker, الدكتورة سماح أبو رحمة, a neuromuscular. She has a neuromuscular fellowship at the University of Colorado, and she is an associate professor and consultant at the Georgia University of Science and Technology, and an active member of the American Academy of Neurology, European Pediatric Neurology Society, and Georgian Neurosurgical Society. You are more than welcome, Dr. Samah. Go ahead, please.
يعطيكم العافية. صار شوية confusion بالنسبة لعنوان المحاضرة. كانت initially genetics وبعدين إجاني مسج إنه your lecture entitled neuromuscular investigation، فرجعت غيرتها للنeuromuscular investigation. جيت اليوم اللي هي على البروشور genetics. There are genetic investigations in the lecture, but يعني that's fine. بس we'll talk about it of course. هلا انتو medical students في سنة أولى، سنة أولى، سنة ثانية، سنة ثالثة، وفي رابعة، خامسة، وفي سادسة. ماشي. So this lecture, I hope إنه تكون فعلاً geared towards medical students. I'll try not to make it too technical, too complicated. ولأنها towards medical students، صح هي اسمها navigating neuromuscular investigations, but at every turn, at every step of the investigative process, we will stress the importance and the value, the unparalleled value of your history and physical examination. Okay, هذول the tools of your trade. Okay. History and physical examination are the guiding light for any investigation that we perform on any of our patients, okay? For the neuromuscular patients, like any other patient, the first question, is this a neuromuscular problem? Is this genetic or acquired? خصوصا in pediatrics, this is the major question. Is this genetic or acquired? Maybe more so than in adults. And if so, where is the problem? Neuromuscular patient, is it in the brain? Is it in the spinal cord? Is it in the neuromuscular junction? Is it a myopathy? Is it a neuropathy? Where is the problem exactly? And this is what we aim our investigations at, to answer all of these questions. زي ما حكينا, it starts with the history and physical examination. History and physical examination. I cannot stress it enough, okay? We teach you بالسنة خصوصا بالclinical years لما تيجي بنحكي عن برابعة وبنحكي بخامسة وبنحكي بسادسة. We always stress your history taking skills and your physical examination skills, okay? يعني no number of advanced, expensive, or sophisticated investigations can take the role of your history and physical examination, okay? In history and physical, I look at it as the guiding light for everything else. يعني So your history and physical examination are the guiding light. يعني أنا بشبه all of the investigations that we perform in labs, in advanced, radiological investigations, molecular investigations, genetic testing. هذول كلياتهم without a good history and physical exam are like shooting in the dark. Okay? بتصير any abnormality that faces you in any of these investigations will act as نحكي لها red herring. You will start following any abnormal lab or any abnormal radiological investigation without knowing where you're heading exactly. Okay? خلاص? So with neuromuscular patients, we have labs, we have nerve conduction studies that are unique to neuromuscular investigation, to neuromuscular studies. A lot of genetic testing. I think genetic testing now is where everything is at, particularly with neuromuscular diseases. Muscle biopsy, plus minus, I think, يعني بنحكي عنها شوي in the course of the lecture. And then we have imaging studies, مش رح أحكي عنهم in this lecture, neuromuscular ultrasound and also muscle MRI. Okay? هدول كلهم investigation that can aid us in our history and physical examination. When we want a history and physical, what we aim at is to have an accurate, what we call phenotype for the patient. If you do not have a good phenotype, which is the clinical expression of a disease, particularly طبعا نحكي phenotype, we are talking about the clinical expression of a genotype. If you do not have a good phenotype through your history and physical examination, you will not be able to reach a correct diagnosis, even with the most advanced testing that you have. Okay? فالhistory with physical, it's a system that works. لهيك it's the same thing اللي أنا تعلمته بالميديكال سكول واللي تعلموه قبلي, for maybe hundreds of years now, history and physical examination. It is the system that works for reaching a diagnosis for patients. Okay? But these are the tools of your craft, the most important tools of your craft. I would advise you to really work hard on honing in on your history and physical skills. So, أهم sign or presentation for neuromuscular diseases is weakness. Okay? So, is it proximal? Is it distal weakness? If you have proximal weakness, عادة we have a problem with sitting up مثلا from bed. Trunk weakness, we have a problem getting up from the floor. And if you have distal weakness, عادة we are dropping objects or we are tripping. بصير يتعلق even الطفل بإجرين. We have to examine muscle groups against gravity. This is something طبعا أكيد clinical الطلاب اللي clinical stage will appreciate. Clinical examination, we aim at examining deep tendon reflexes. We look at evidence of central issues. Is the child or the patient encephalopathic? Does the child have spasticity? Does the child have hyperactive reflexes, etc. هلا بالنسبة للgenetic muscle diseases, في something very particular in genetic muscle diseases, they have a lot of tropism. What does tropism mean? It means that there is high selectivity of muscle weakness. It's not a generalized weakness like that we find in a child who has, or a patient who has dermatomyositis, polymyositis, those are acquired inflammatory myopathies. They do not have the selective properties of genetic muscle disease. So anytime we find high selectivity of involvement of muscles, بنفكر genetic muscle diseases. And these are some examples of tropism in muscular dystrophies. Tropism, if you look at this patient مثلا, this patient has what we call a diamond on quad sign, which means that there is atrophy of the whole quadriceps except for the quad نفسه, the vastus lateralis, medialis, هذول كلهم they're atrophied except for one part of the quad. So you can see this high selectivity. This patient has مثلا facioscapulohumeral dystrophy. هذول they have selective atrophy of the proximal deltoid and intact distal deltoid. فتخيلوا إنه within the same muscle you are having selective involvement. Whenever you pick up selective involvement of muscles or muscle groups, this is when we start thinking of a muscular dystrophy, we do not see this selectivity in مثلا inflammatory muscles. Okay, so this is for genetic dystrophies. Lab investigations. بدي أحكي عن elevated liver function tests. We need to remember إنه liver function tests are also muscle enzymes. Liver enzymes are muscle enzymes. This child مثلا from our clinic, he presented with elevated ALT and AST, which were incidentally picked up. Extensive testing, including even a liver biopsy. Ultimately, someone thought of maybe this is maybe an exhaustive list of شاف neurologist. They presented to me after having done genetic testing for Duchenne muscular dystrophy, which turned out to be positive. So this child was even diagnosed prior to diagnosis, which is to onset of clinical features, which is not always, يعني بالنسبة للدوشين where no definitive treatment, not always advantageous. So liver tests are not always liver tests. لما نحكي عن lab investigations for muscle diseases نحكي عن ALT و AST و CPK. GGT is the test that can differentiate between liver damage and muscle damage. Okay, so anytime we have elevated quote-unquote liver enzymes, we should think of muscle diseases. We have to remember that CPK is not always elevated in muscle diseases, and CPK can be elevated in even neuropathic diseases. يعني مثلا with adults, I think maybe you see a lot of elevated CPK بالradiculopathies. مثلا عندهم disc, they may have some elevation of CPK. Again, guided by the clinical picture and the history and the physical examination. فهدول اللاب تيست. نيجي هون على nerve conduction studies and EMG. Again, accurate phenotyping. بس أنا بدي أعملها. So accurate phenotyping. This is a child who presents with slowly progressive gait deterioration. He was sent to our lab for evaluation of Charcot-Marie tooth. لأنه عنده characteristic. You will learn probably about them in your clinical years. عنده hammer toes, عنده pis cavus. Like when we examined him, we found that he had hyperactive reflexes. He had clonosome examinations. So these are central signs which do not go with Charcot-Marie tooth. So we can do the most extensive, nerve conduction studies, genetic evaluation, okay, and not reach the diagnosis. This child needed a genetic panel for مثلا spinocerebellar atrophies, okay, spinocerebellar diseases. Okay. Again, the value of your history and physical examination. This 8-year-old, proximal muscle weakness, hypertrophied calves. Genetic testing was not available at the time. هذا الحكي probably more 5-6 years. We didn't have a lot of access to genetic panels. Someone, طبعا he was يعني إجا علي. We thought this is most likely a muscular dystrophy, most likely a Duchenne muscular dystrophy. They like to doctor shop. So someone sent them for a muscle biopsy. The muscle biopsy was interpreted as inflammation, as an inflammatory cells. على طول he was, sent for IVIG, steroids. He was diagnosed as having a possible polymyositis. But if you look at the clinical picture and the history and physical, they do not go with polymyositis. Despite the fact that sometimes we think, tissue diagnosis, this is the ultimate diagnosis. Despite the fact that he had inflammatory cells, his clinical picture did not go with having an inflammatory myopathy. Okay, so he was misdiagnosed, and his diagnosis and treatment was not guided by the clinical picture that he had. So he was misdiagnosed, false hope, this is inflammation, you will respond to IVIG, etc. Like ultimately, with genetic testing, it was proved that this was a Duchenne muscular dystrophy. Like طبعا parents والمريض, they went on a psychological journey that was not easy for them. Okay? So muscle biopsy, just okay, so there was a picture one just showing several slides of a muscle biopsy, one an inflammatory with polymyositis, one with Duchenne muscular dystrophy, and one with FSHD, which is another genetic muscular dystrophy. All of them having inflammatory cells, okay? So you can have an inflammatory looking muscle biopsy with a genetic muscular dystrophy, because anytime you have necrosis, شو بصير في عندنا ردة فعل in the body? You have inflammation, to clean up the necrosis itself. So there is an inflammatory component. So not having a good clinical history and physical exam can lead to misdiagnosis, even if you do a tissue biopsy. Okay? هاي شغلة بنحطها. Genetic diagnostic. Why should we do genetic diagnostic? What is the value? Okay? The first value for me is reaching a definitive diagnosis. And once you reach a definitive diagnosis, you don't have to do any further testing for the patient. مش رح تبعته يعمل other lab investigations, biopsies, nuclear studies, etc. خلاص, the investigative process stops once you reach a definitive diagnosis. Sometimes it can, طبعا genetic counseling for recurrence, okay? But sometimes even in diseases where you don't have a specific treatment, you may be surprised, okay? يعني مثلا عندنا هدول أحكي عنهم just على السريع. هدول they are siblings, okay? They presented with what looked like a congenital myopathy. فعلا عملنا لهم neuromuscular panel. They had a mutation, had a Kelch protein. They have a mutation that's consistent with highlighted with a Nemelin myopathy. Okay, it's one of the newer mutations that have been associated with Nemelin myopathy. عملنا research or literature research زي ما حكى الدكتور أحمد about the importance of research in furthering our clinical practice as physicians. فلقينا إنه this new mutation recently people are reporting on the value and the benefit of acetylcholineesterases because there is involvement of the neuromuscular junction. So unexpected to me, I did not expect to find, I only expected to find the diagnosis, like unexpected to me, their mutation may be amenable to emerging therapy. So sometimes you can be surprised. It's not always إذا في علاج we want the diagnosis إذا ما في we do not. A diagnosis is always of value, always. Even if there is no treatment, a definitive diagnosis is always of value, okay? طيب هلا هون في كتير آخر كم slide just to wrap things off. I think everybody now West رايح West جاي, everybody wants to do whole exome sequencing. What is whole exome sequencing? بيجي المريض والدكتور عملنا whole exome, thinking إنه معناته they covered everything. We have to remember in the whole exome sequencing is a targeted test. What do we mean by targeted test? يعني اللاب اللي انت بتبعت له whole exome sequences, they are guided by the phenotype that you provided to the lab. Okay? إذا أنت بتقول للمريض لللاب أنا مريضي عنده ataxia وبتبعت له يعمل whole exome sequencing, you will get a report for ataxia genes. إذا مريضك ما عنده ataxia وعنده dystonia for example, you will not have tested for dystonia gene, you will have a negative result. Okay? This is what whole exome sequencing is. يعني this is an example of an 11-month-old frequent seizures. This is her whole exome sequencing. إذا بتطلع الwhole exome sequencing تبعها مش واضحة هي هون, لكن الphenotype provided to the lab was suspicion for metabolic diseases because the MRI had some white matter changes. The radiologist added this is suspicious for white matter disease, maybe metabolic. So the phenotype provided to the lab was, this is maybe a metabolic disease. فإيش تيجي النتيجة؟ There's a variant of unknown significance, يعني مش معروف بالضبط for, I think it's NCL, neuronal ceroid lipofuscinosis, which is a very bad progressive neurometabolic disease, but it's a VUS, variant of unknown significance. يعني هل هي pathologic أو لا? No one knows. فيجوا الأهل in their mind, this is what the patient maybe has. This is a pathogenic, mutation. Clinically, الphenotype تبع المريضة إيش? is not that of a progressive metabolic disease. She only had seizures. She was normal developmentally. But it doesn't make sense clinically إنه هالمريضة عندها metabolic disease, even if the MRI shows that. لما بعتنا لها panel, epilepsy panel, not neurometabolic panel, بعتنا لها epilepsy panel, the diagnosis came back and she has an SCN8, which is associated with benign neonatal seizures. So she had a benign disease. And we were able to prognosticate that she will probably outgrow her seizures. So again, we are talking about the value of phenotyping. And if there's anything, the main point I'm trying to drive home is the importance and the value of a history, clinical examination, and an accurate phenotype. Without them, as you can see, even the most sophisticated testing will lead you on an unending diagnostic odyssey of mistakes. Okay? So phenotyping, in summary, continues to be the backbone of any diagnostic approach. We need to trust the system. Trust the system. History, physical. مثل ما بنعلمكم اياه HPI والanalysis. هذا كله مش لأنه بدنا نحشي وراه، لأنه this is the only system that gets you to a diagnosis. It's the only way you can help your patients. The muscle biopsy has limited implications. أهم شيء بالgenetic test إنك to know which genes are included. Maybe حتى even a comprehensive neuromuscular panel. Most labs with comprehensive neuromuscular panel do not have Duchenne muscular dystrophy on the list. But إذا أنت شاكي بدوشين, you have to look at the list. موجود الجينيتك تيست ولا مش موجود؟ Okay? And thank you.
شكرا دكتور سماح. إذا في حد حاب يسأل سؤال أو سؤالين. بس
كم كانت موازنتك؟
لا ما تسألني بس الدكتورة سماح.
لا
مش موازنة. لا بعدين هاي لا خلص. فات
محاضرتي.
Any questions?
طيب اوكي هلا احنا our next speaker is دكتور خالد العلاونة. دكتور خالد طبعا اخصائي موجود عندنا بالمستشفى. He has German Fellowship of Diagnostic Radiology from Germany. He's an associate professor of interventional neuroradiology at Just KUH, and he is a consultant in JFBA committee and member of the European Society of Neuroradiology. اليوم راح يحكي لنا على النيورو انترفنشن. شكرا دكتور خالد.
يعطيك العافية. صباح الخير يا باشا. طب أنا نسأل حدا بيعرف شو النيورو انترفنشن؟ حدا عنده فكرة أول شيء؟ ما حدش بيعرف؟ تفضل.
الانترفنشن يعني قصاص او شيء زي هيك، هو انك تدخل تعمل عمليه ونفس فكره الانذار تقريبا، انك تعملها كامله بس بدون ما انك تعمل انسجن.
اوكي. So it is endovascular. احنا بنحكي عن سب سبيشاليتي endovascular neurology, neurosurgery or neuroradiology.
بس تكون بتعتمد على الاكس راي.
Yeah. It is minimal invasive procedure, image based. So we have many names for this subspecialty. All are depending on endovascular approach to the blood vessels of the brain or the spine. And we have many pathways to be a neuro-interventionalist. And the most common is the interventional neuroradiology, and nowadays we have neurosurgery, endovascular subspecialty, and as well in neurology. We will just go through the history of the progression of the neuro intervention. So the first one to do cerebral angiography was Professor Igas Moniz. He was a neurologist from Portugal, and in 1927, after 30 years of the discovery of X-ray by Röntgen, he made the first cerebral angiograph, and regarding that, he was one of the winners of Nobel Prize. And he was also performed the first lobotomy in psychosis. And this is the first cerebral angiograph was done. And the first one to make the entrance or the sheath for femoral puncture was Slinger. He was a Swedish radiologist. In 1953, he introduced the procedure using the sheath and arterial needle and wire. And also he was one of the winners of Nobel Prize regarding that. And in 1964, a radiologist from Norway, his name is Bear Amundsen, was the first to perform a complete brain angiograph for the transfemoral approach as it is performed today. And in 1958, the first angiosuite was cardiac angiosuite was also established in Ohio. And nowadays we have very modern angiosuites with biplane and 3D and 4D option. For the interventional treatment, the first to carry endovascular procedure was the American Dr. Charles Tutter, and he was the father of angioplasty, or the father of interventional radiology in the world. He performed therapeutic angioplasty for the superficial femoral artery. But the father of neurointervention was from Russia, Professor Fyodor Serbenenko. He developed the technique for treating the aneurysms for brain using two balloon models, one as balloon assisting detachable balloon. We will see how he used catheter with balloon assist detachable balloon inside the aneurysm, and it was successful procedure. And during the next years there was many complications of this technique, since sometimes these balloons are deflated and then make occlusion of the artery. In 1979, the digital subtraction angiography was performed first, and this means we can just see the blood vessels without see the bone. And it was also a revolution in the seeing of blood vessels, arterial and venous system inside the brain. About the treatment also for the aneurysm between 1980s and 1990s, the neuro intervention suddenly made a revolution by Italian physicians, Giantrico and Goglielmi. These two make the revolution of using coils, metallic coils. And in the second half of 1980s, Sadiq Hilal was the first in Columbia University to use coil to treat a brain aneurysm, but the problem that was not controlled coils. Controlled coil means electric control for these coils, so we have many problems in this technique also by occlusion of the patent vessels. And the Goglielmi coil was the first detachable platinum coils with electric control. Until now we are based on this technique for simple coiling for the aneurysms. And from the start of 2000 and to now, we have many devices, tools, and many revolutions inside the procedure and techniques in neurointervention. We use many procedures for aneurysm, like simple coiling. The coils now are extra soft and more softer than the first generation. And we use for widening aneurysm new technique like stent assist coiling or balloon assist coiling. And we have the revolution of a flow diverter stent also. That was open cell stents and will preserve the normal vessels when we occlude the aneurysm. And for the stroke, we have also mechanical thrombectomy and many procedures to use like stent retrieval. And this is the new biplane angio suite with a 3D and 4D angiography. These are some of the new tools that we use, the flow diverter. And if you can see, here we have the internal carotid artery, and there is aneurysm with vessel near this aneurysm to make closed cell stent that will occlude the normal vessel. So it was really to use the flow diverter and revolution that we preserve the vessel like here and the aneurysm was done. And we have many also techniques like stent assist coiling and balloon assist coiling. For arteriovenous malformation in the brain, also there is many tools to use, like liquid embolic materials. We have onyx and fill to make embolization of the nidus with this dense material inside the nidus of the AVM. What we can treat in our subspecialty: cerebral aneurysm, brain arteriovenous malformation, carotid cavernous fistula, dural arteriovenous fistula, many vascular tumors, nasopharyngeal tumor, and meningiomas, sometimes with cooperation with the neurosurgeon. Some of these procedures should be followed by a neurosurgical resection, and for the stroke as well. How to be a neurointerventionalist? We have really three main programs to be a neurointerventionalist. Neurosurgery residency from 5 to 8 years, followed by interventional neuroradiology fellowship from 1 to 2 years, for total 6 to 10 years. Diagnostic radiology residency 4 to 5 years, followed by neuroradiology fellowship 1 year, followed by interventional neuroradiology 1 to 2 years, for total of 6 to 8 years. In neurology residency 4 years, followed by stroke or neurocritical care fellowship 1 to 2 years, followed by interventional neuroradiology fellowship from 1 to 2 years, 7 to 8 years. The most common program is radiology, to be neuroradiologist, and then interventional neuroradiologist. In USA, they use the two of neurosurgery residency and the neurology residency, followed by interventional neuroradiology. In West Europe, still it is not allowed. Just in some centers they allow neurology or neurosurgery to do these procedures. In our hospital here, and since it is a university hospital, we have many achievements in neurointervention with cooperation with the neurosurgery. We have many novel techniques published in many, or in the most reputable journals. The first one was about treating arteriovenous malformation with a new technique of endovascular and surgical devascularization. And then this was just for discussion the technical strategy, and this was a full article about our method. Like in this, we have arterial feeder, we have the nidus, the body of the arteriovenous malformation, and the draining vein. There is a classical way is to embolize the nidus with liquid embolic material. Our technique was just to make embolization and devascularization of the pathological distal feeder to the nidus, followed by surgery. And this is the one of the high flow AVM, and treated by at first devascularization technique by onyx, followed by surgery, and then get rid of the AVM. We are the only center in Jordan we have this cooperation and the region to have a neuro intervention with cooperation with the neurosurgery to make surgical resection. Another case for a boy 4 years old, have small AVM after devascularization technique, then followed by surgery, and the last limit there is no AVM. Another novel technique, and we submit this technique for the United States Patent and Trademark Office, and they accept to discuss that, and we are waiting for the decision. It is the successful use of neurovascular blood for embolization of scalp arteriovenous fistula, and it was published in the Journal of Endovascular Therapy, one of the most famous journals in the field of endovascular. And this is the vacancy. We send it, and we are waiting. It was for a 10 years at that time boy suffering from versatile mass in the skull, and after angiography that we see the temporal artery is in with pseudoaneurysm with many venous drainage to the superior sagittal sinus and to the facial vein, and was treated by a new device in this place. That's the neurovascular blood, as we call it. And the end result was successful, get rid of this fistula, and we follow up the patient for 6 years. And the result was there is no recurrence. الفيديوز مش اشتغلت، هون في عنا كمان فيديو كمان بنحاول كده بشغلوه بعض. يعني how to see the solitaire or any stent retriever for mechanical thrombectomy of the stroke and many procedures. ما راح يشتغل. موجود. Okay, thank you very much.
Thank you, Dr. Khalid, for your presentation. Any questions for Dr. Khalid Alana? Yes, please.
يعطيك العافية أول شيء دكتور على المحاضرة. دكتور أول شيء بسألك سؤالين على السريع. هلا أنت زي ما تفضلت في ثلاثة باثويز إنه الانترفنشن نيوروراديولوجي. بدي أسألك عن النيورو ميديسن باثوي. هلا هو مثلا بدأ بأمريكا، باقي العالم مش بادي كثير، لأن النيورولوجيست يصير نيورو يعني انترفنشنال. فأنت برأيك شو الأدفانتجز بهالموضوع؟ disadvantage وشو الليميتيشنز ما راح يتمكن منها. ثاني شيء عن الاي في ام بعلاجها، متى بتعرف انه لازم تعالج ومتى لا؟ كومبليكيشنز بشكل سريع. يعطيك العافيه.
هلا بالنسبه للباثويز احنا بنحكي انترناشونال باثويز، امريكا لان في لاكي كثير بالانترفنشنال نيوروراديولوجيست اول شيء، فهم فتحوا البروجرامز للنيورولوجي حتى يروحوا باتجاه الستروك والميكانيكال ثرومبكتومي والنيوروسيرجري باتجاه الانيوريزمز والاي في ام. المشكله اللي صايره انه البروجرام مش كافي حتى بالوسائل يعني 1 year بعضهم بيجيبوا مثلا فيلوشيب نيورولوجيست، وفي عندنا مثلا هون باد ريلي اكسبيرينس انه في منهم بيجوا بيشتغلوا انيوريزمز وكل شيء وذ باد، بينما في عندنا مثلا بعض الفيجرز. في عندنا دكتور من عندنا كان تكنو محمد غانم، يعني واحد من الشباب اللي ما شاء الله يعني شغله ممتاز والان باريزونا، وبس يعني ماشي بستيب صحيحه وشغله كويس كاكسبيرينس. الافضل بروجرام بالعالم هو النيوروراديولوجي بعدين انترفنشن. في موضوع مهم اللي هو الاويرنس اباوت راديشن. لما تكون انت نيورولوجيست نيوروسيرجري بعض الاحيان ما بيكون عندك ذات الاويرنس، وهذا الحكي موجود بعض الكارديولوجيست لما يشتغلوا حالات كثيره وما بيعرفوا حتى ما بيحطوا شنارة كبشه للتيرويد. فالراديولوجيست دائما بيكون اوير اكثر. الشيء الثاني اللي هو البروسيسنج خلينا نحكي interpretation of the images. برضه الراديولوجيست بيكون عنده قدره اكثر من النيورولوجيست واكثر من النيوروسيرجن انه يشتغل. المشكله الثانيه كمان انه مش بس هذا البروجرام السيرتيفيكيت المعترف فيه، لان في دول كثيره الكارديولوجيست بيشتغل النيورو انترفنشن والراديولوجيست بيشتغل انترفنشن. فالافضل دائما تروح باتجاه الراديولوجي وتضل ماشي بالبروجرام، انا بشوف افضل شيء الا اذا صار في تعاون. يعني في بعض سنترز زي هايدلبرغ بجرماني جابوا بعض النيوروسيرجن والنيورولوجي بلشوا يشتغلوا بس ضمن سوبرفيجن كامل، انهم يرجعوا ياخذوا راديولوجي سنه وبعدين يروحوا على الديagnostic نيورولوجي وبعدين يروحوا للانترفنشن. بالنسبه للسؤال الثاني الاي بي ام البرين اي بي ام، احنا دائما عندنا كوميتي. الكوميتي هذا لازم يكون في نيوروسيرجري مع نيورو راديولوجي، ونقعد احنا بالضبط نحط في عندنا سبيشال ماركتنج كلاسيفيكيشن للتريتمنت، جريد 1 جريد 2 3 4 5 6. سو مثلا جريد اب تو 4 دائما هذا نعمل له امبولايزيشن بعد ريسكشن. 5 و 6 بدنا احنا نعمل له زي باليتيف تريتمنت، نعمل له بارشال امبولايزيشن.
حضرتك ذكرت او دكتور عرف عليك انك تفلشوا في جيرماني، ففي معلومه سمعتها حابب اتاكد صحتها منك انه هسه في جيرماني الميديكال ابروش او النيوروسيرجيكال ابروش بشكل عام ميديسن، هل يعني مختلف عن الكونفشنال اللي بيعرفوه يعني معظم العالم في معظم العالم؟
ما فهمت عليك كيف؟
الابروش تبعهم في الدايجنوستس وفي التريتمنت بالذات التريتمنت، سمعت انه مختلف او انه بيحاولوا يختلفوا عن باقي العالم.
هلا هي سكول بالضبط، الجيرمان سكول تختلف بس كلهم مع بالتالي بصفوا شيء واحد اللي هو هلا بالعكس يعني احنا كل المواد اللي نشتغل فيها مثلا الاجهزه اكثر شيء بطلبها امريكا. اذا شفت انت اكثر من يو اس ساينتست هو دائما بيضلوا فيها، امريكا كبيره فيها لاكي كثير بالضبط. الجيرمان شوي ريستريكت بالبروجرام ولذلك هم شوي نجحوا بالنيورولوجي اكثر من عندهم فيجرز كبار. انا كنت في انترناشونال سبورت سنتر، كان واحد منهم اسمه رودريغيز من توما، واحد من البيست وكان برضه الجيرمان تاع السيتي واليوروبيان، وكان يروح فيزيتر في نيويورك فيزيتر بروفيسور يعني لما نحكي عنه. فما في يعني هي سكول واحده، بس بضل انك تريني لما تتدرب لازم تاخذ جود خلينا نحكي ب 1 year not enough to be intervention neuroradiologist you will be killed. لان اذا ما كان عندك solid experience solid training راح تيجي على مشاكل كثير. الاهم not how to treat، اهم شيء انك صار معك communication how to see this communication. احنا بصير عندنا communication نشتغلهم، وعندنا هون سنتر عندنا كثير نشتغل شغل كويس، وحابين يصير عندنا ستروك سنتر وان شاء الله انه يرى نور قريب. يعطيك العافيه.
The fellowship in stroke from the University of from Canada and Canadian fellowship in multiple sclerosis from Canada as well. And she is working as a brain and neurology specialist and had a Jordanian board of neurology and brain diseases. Welcome to Mace.
Thank you. Thank you, Dr. Sistema, for your kind introduction. While they're trying to open up the slides, first of all, I want to thank the organizer for this conference. وأكيد طبعاً دكتورة إيثار ودكتورة عمر جبارة والنيوروسيرجري ديبارتمنت وكل القائمين including medical students who participated significantly in this conference. النقطة الثانية, it's very difficult to present something in front of my mentor, Dr. سماح أبو رحمة, as I'm always inspired by her. لما كنت medical students أنا داومت معها وكان الله يسهل عليه دكتور رامي العذب. قبل ما أعرف دكتور سماح أبو رحمة كان يضل يحكي لي سماح أبو رحمة فيكي شبه منها، فأنا بتشرف إنه يكون في شبه من دكتورة سماح أبو رحمة. وطبعاً we are all inspired by Dr. أحمد ياسين and his motivation and also Dr. Khalid Alauna. So let's start our topic for today. I know it's probably a difficult topic for you guys, especially the basic years folks, but I will try to make it easy as I can. So our topic is about embolic stroke of undetermined source, of undetermined etiology. It's kind of new emerging concept in neurology. I always stress about the importance of recognizing the etiology and the cause of stroke. So we always have stroke cases coming to the emergency department. We can all treat the stroke acutely, but the most important point is to try to identify the etiology because it influences the acute management as well as the secondary stroke prevention strategies or techniques. I have no disclosures or conflicts of interest. So to introduce you to the idea of stroke etiology, I made up a couple of very short cases. So the first case is about 65-year-old man with multiple vascular risk factors, including poorly controlled diabetes, as we can see in his hemoglobin A1C, hypertension, dyslipidemia, and smoker. And this patient presented with right-sided weakness and dysarthria. NIH, maybe you cannot understand what's NIH. It's part of the neurological examination, is estimating the degree of deficit. So the NIH was 8. And I will not talk about the acute management, but in this case, we want to try to find what's the exact etiology of his stroke. So we made some investigations, including cardiac investigations, ECG monitoring, Holter monitoring, looking for atrial fibrillation, and it was normal. And the echocardiogram also did not show any clots and was normal. So based on the images, here we can see the MRI. We have this area. Do you see my cursor? This area of stroke and this area as well as this area. And it's called border zone stroke or border zone infarction. And when we see this stroke, we have to suspect atherosclerosis as the etiology of stroke. And this was the case actually. So the CT angio showed a couple of areas in the common carotid artery and the internal carotid artery showing significant areas of stenosis. Why it's important again to know the etiology or the cause of the stroke, because the management can be different acutely and secondary prevention. So in this case, what do you think that we can do with this patient? Any suggestion? تفضل.
هلا ممكن انا قرات انه لو البريك اكبر من 90% من الفيسل ممكن انترفنشن او ممكن ستنت او
Great. So yes, if there is significant area of stenosis, to simplify the idea for you guys, we can open up the vessel, clean it up, and the source of embolization will go away, or we can dilate this area by stenting. So we can do either carotid artery stenting or carotid end arterectomy. The next case is 78-year-old right-handed hypertensive woman who presented with aphasia, right-sided weakness, left gaze preference, and right homonymous hemianopsia. So the patient has significant deficits on examination, and when we checked the carotid, the blood vessels from the heart to the intracranial vessels, we found that at the neck there is no area of significant stenosis. However, there is area of occlusion intracranially, and we can talk about that in a couple of seconds. But importantly, during doing cardiac investigations, we noticed that this patient has atrial fibrillation. Sorry. So by looking to the stroke size, location, and the significant degree of impairment, neurological impairment, we expect the cause to be due to large stroke. And when we expect large stroke, we expect some proximal source, probably the heart, because it can carry large clots in the heart chambers. So this actually what happened, and this clot from atrial fibrillation from the heart chambers went and closed the middle cerebral artery. So what do you think the best management will be? Not in the acute, I'm not talking about if the patient presented to the emergency immediately and received TPA. After that, what do you think that we can do? تفضل.
cardiology consultation getting started.
Okay, تفضل. Exactly, anticoagulation. We need anticoagulation in this case. The third case is about 68-year-old man with poorly controlled hypertension presented with left dense hemiplegia. Dense hemiplegia means that the face, arm, and leg are involved in the same degree. So the CT angiocarotid did not show any areas of significant stenosis in the neck, and the echocardiogram, Holter, ECG were all within normal limits. And when we, when we did the brain MRI, we found a little stroke here in the posterior limb of the internal capsule. And when we see this location, it's common and typical for what we call small vessel disease. We have in the brain small penetrating or perforator vessels that go deeply in the subcortical area, supply deep structures. With chronic hypertension, there is some changes that can happen to the vessel wall, and accordingly, stroke can happen. So this is again different etiology of stroke. So again, what's the best management in this case? تفضل. Exactly, it's risk factor management, including hypertension management, which is the most important point. The last case is 37-year-old previously healthy woman who presented with cervical pain, vertigo, imbalance, and vomiting. Again, the cardiac investigations were normal. However, since the patient is young, it's unlikely to see multiple vascular risk factors in young people, and also it's not common to see atrial fibrillation in this age group. So, what do we expect if we see young patients with a stroke? One of the most common causes of young people with a stroke. Could be, but one is more common.
Thrombophilia.
Other than thrombophilia, تفضل. عفوا. Thrombophilia. Oral contraceptives. Okay. AVM, no. All are reasonable answers, but dissection. So in this patient, we can see here that there is, you see this vertebral artery, the right vertebral artery diameter, and the left vertebral artery, and here clearly we can see some changes to the left vertebral artery, resulting in a stroke in the left cerebellum. So this is a different cause of stroke, and it has different management, including primarily antithrombotic treatment for secondary prevention. So those examples. Where? Should I continue?
Yes.
بدكم تشوفوا slides يا جماعة. أنا بقدر أكتب بس بدهم يشوفوا. طيب أوكي. شغال المكتب أوكي. So again, we have multiple causes of stroke. علق الكمبيوتر كمان معلش. استنى شوي. التليفون موجود نعم. طيب نكمل من التليفون. اوكي. So معلش هلا ححكي شوي بعدين نشوف السلايدز اللي راحت علينا رجعوا. طيب ممتاز. Okay. So we have widely adopted old classification stroke, very old. It's called Toste classification, and we still use it. So it classifies the stroke into large vessel atherosclerosis as the first example. What we see, or we can see in this case, that there is areas of significant stenosis, more than 50% stenosis in the extracranial carotid arteries, small vessel disease, the penetrator, and cardioembolic sources, which can be due to atrial fibrillation or due to valve disease, infective endocarditis, for example, and uncommon determined etiology, as we mentioned, like in vasculitis or in dissection. But there is one. Okay. There is something called cryptogenic stroke in the TOST classification. Can we share the slides? Okay. Cryptogenic stroke. So what do we mean by cryptogenic stroke? So it's a very wide term, and they used to label patients who are fully investigated with, for example, cardiac investigations, visit investigations, and they don't find any etiology for the stroke with cryptogenic stroke, or patients who didn't do investigations. For example, the patient passed away before doing the investigation or was terminal, or the patient did not have enough investigations. All of these groups of people were categorized under the cryptogenic stroke. So it was very difficult, not reproducible concept, and very difficult for the research purposes and for the treatment for secondary prevention. Accordingly, sorry, this is the cryptogenic stroke, I just mentioned them. So accordingly, the ESIS working group in 2014 adopted a new concept which is called embolic stroke of undetermined etiology, to make studies, to make differentiating people much easier. As I mentioned, that they used to group people who are fully investigated without clear cause with uninvestigated people. So what do we mean by ESIS? So ESIS is non-lacunar ischemic stroke in which sufficient diagnostic assessment excludes major risk cardioembolism and proximal arterial stenosis. And we have criteria to diagnose ESIS. So there should be non-lacunar stroke, and to define lacunar stroke, it's defined by typical location, which is generally subcortical in the distribution of the perforator vessel or the penetrating vessels, and the size as well in the MRI, which should be less than 1.5 centimeter in the MRI sequences, except for one sequence which is 2 centimeters. And there should be absence of extracranial or intracranial atherosclerosis more than 50%. More than 50%, and there is no major risk of cardioembolism, and no other causative agent can be found, like dissection, arthritis, drug abuse, and others. So what kind of investigations we have to do before labeling somebody with ESIS? We always have to do brain imaging, regardless if it is brain CT scan or MRI. We have to do heart monitoring by ECG, 12 leads ECG, echocardiogram, either transesophageal echo or transthoracic echocardiogram, and we need Holter monitoring and imaging of the vessels from arch to vertex, either by MRI, CT angio, DSA, or even Doppler ultrasound with transcranial Doppler. So how common the ESIS in the population? ESIS accounts for approximately 1/5 of all ischemic strokes, and this result was consistent across multiple trials, including all global regions. And the recurrence rate was 4.5 to 5% annually, which means that medications or treatment strategies should be investigated further to prevent this high risk of recurrence. And it was noticed that patients who have embolic stroke of undetermined etiology, that they have less severe strokes than other, for example, cardioembolic strokes. The source of emboli in those patients can range from something related to the heart or to the vessel, and it's different between age population, and we are going to talk about this. Up to 30% of ESIS patients were found to have paroxysmal AF, atrial fibrillation. However, at the beginning, when the concept of ESUS emerged, they thought that atrial fibrillation was a major causative factor for ESUS. However, these days we think that it's less common as we thought initially. So those are the potential causes of embolic stroke of undetermined source or etiology. It can be from the heart, like valvular heart disease, like patent foramen ovale, atrial cardiomyopathy, covert atrial fibrillation, left ventricular disease, atherosclerotic plaque resulting in less than 50%, because we know that more than 50% stenosis definitely results in stroke, and hypercoagulability and cancers. So this is a good paper about the features and frequency and characteristics of patients with ESUS, with young patients in general with ESUS. And I want to mention a couple of points here. It was found that traditional vascular risk factors are much more common in older patients with ESUS rather than young. For example, if we look to hypertension, it was statistically significant difference between young and old patients. Same with multiple other risk factors. So vascular risk factors are much more common in older people with ESUS than young people. But also it's very important to know that the median NIH score, which means the deficits, and the mortality within 30 days were similar across both groups, young and older age population. So going quickly through the potential causes of embolic stroke of undetermined source of etiology, we have the patent foramen ovale, if you have heard about it before. So the patent foramen ovale is very common, and maybe it can be found in about 1/3, maybe quarter to 1/3 of the general population, and it's not always a causative agent of stroke or any abnormality. But we assume sometimes that there is paradoxical embolism originating as venous thrombus and entering the arterial system via this intra-atrial defect. And there were multiple trials previously before the introduction of the ESUS concept in 2013 and 2012 about what's the best management strategy for those people. And all of the previous, all the trials failed to show that PFO closure, closing of that defect, let's say, is superior to medical therapy. But the case was changed after the introduction of the ESUS concept. So we have multiple trials, including reverse, respect, and closure, which showed that closure of the PFO reduces the risk of subsequent ischemic strokes in carefully selected population. So when we mention that carefully selected population, this means that not every stroke patient with ESUS have to go for this procedure. There should be certain characteristic features. I will not go through them because it's maybe complicated. 3 minutes? Okay. I will try my best. And the next possible cause is atrial cardiomyopathy, and it's a very hot topic for research nowadays, assuming that there is some changes to the left atrium, including remodeling or fibrosis, and we have certain features that can suggest that based on the ECG finding or echocardiogram finding or some biochemical findings. And important point is that we have now running a trial called Arcadia about the treatment of this cardiomyopathy, atrial cardiomyopathy, because it was noticed previously that cardiomyopathy preceded the occurrence of atrial fibrillation in large group population. And the next possible cause is supracardiac atherosclerosis. Again, non-significant, less than 50%, but with high-risk feature like ulceration, changes to the vessel wall, which I will not go through them now. And maybe the last, or the ESUS with cancer, so cancer that can increase the risk of embolic strokes by hypercoagulability, by maybe radiation-induced or chemotherapy-induced or immunotherapy-induced. And the last one, as we mentioned earlier, is atrial fibrillation, which is less commonly detected as we thought initially. And we can detect it more in older age population, in people with heart failure or patients with left ventricular abnormalities, for example. This just a summary, but again, I will not go through it. So what's the best treatment for ESUS? So when ESUS concept was introduced, it was thought that it's embolic, so the best treatment will be anticoagulation. Unfortunately, we have multiple trials that have failed to show this. The most important landmark trials for that is the RESPECT ESUS and NAVIGATE ESUS, which included large population group, more than 5,000 in RESPECT ESUS and more than 7,000 in NAVIGATE ESUS trials, and the primary endpoints were for both studies is the first occurrence of stroke, and the safety endpoints again was hemorrhage for both. The Atticus trial is not active actually. It was stopped early with no result published. So the important take-home message from these two trials, since we don't have time, is that there is no clear safety or efficacy data of anticoagulation either with dabigatran or rivaroxaban over aspirin. But in the RESPECT ESUS trial, at the beginning, in the first year, there was no signs or signal for any beneficial effect of dabigatran over warfarin, over aspirin. However, by the end of the first year, those two lines started to separate in favor of dabigatran, indicating that possibly if we extend the trial period for further time, this can show different results. So although both were negative or neutral studies, we have learned from them, and I will mention quickly what we have learned from these trials, that possibly longer observation time might lead to positive results, and different embolic sources are likely to be associated with different ages. For example, BFO is more common in young, and atherosclerosis and atrial fibrillation are much more common in elderly. Analysis of RESPECT ESUS and NAVIGATE ESUS by age indicates that age-related differences in treatment as well. So by analyzing both the studies together, we found that maybe the people who are younger than 60 years of age have beneficial effect of aspirin, while people more than 75 have beneficial effect of anticoagulation rather than aspirin. And impaired renal function was one predictor of major bleeding in NAVIGATE ESUS trial. So the take-home messages here are: embolic stroke of undetermined source is a subtype of cryptogenic ischemic strokes and accounts for about 20% of all ischemic strokes, and the diagnosis requires specific evaluation. Occult paroxysmal atrial fibrillation seems to be as infrequent cause of ESUS as we thought earlier. Atherosclerosis, sources of embolism, particularly high risk non-stenotic plaque, are now recognized as major contributor to ESUS. Neither NOAC, which were the rivaroxaban and dabigatran, were superior to aspirin in ESUS trial and maybe showed some signal for harm. Studies to identify subgroups with ESUS that can benefit from anticoagulation should be continued in further research. And those are my references, and thank you.
Thank you very much for your kind and informative lecture. We can take one question. Any questions, please? Yes?
الله يعطيك دكتور.
الله يعافيك.
هسه بدي اسال في منقرات انه بالنسبه للاتريال فيبريليشن بيستخدموا التيلي مونيتورينج عشان يشوفوها، بس انه بظلهم يتابعوه يعني تقريبا بعرفش كم المده 6 أشهر او 7 أشهر. طب هل مثلا لو هذا فعلا كان كوز ممكن انه نركب لكل واحد المونيتورينج ونسوي هذا الشيء؟
Exactly. So the detection of atrial fibrillation increases significantly with increasing the duration of cardiac monitoring. This is general. So there's multiple trials. I can't remember the numbers at the top of my head, the percentage of detection of atrial fibrillation, but it was found that, for example, monitoring the heart rhythm for 30 days significantly improved the rate of detecting atrial fibrillation more than, for example, 24-hour monitoring. This is completely true. Any further questions?
نعمل مداخلة بسيطة بس على الستروك بشكل عام. بالنسبة للستروك حكت لكم الدكتورة عن احنا بندور دائما عن اذا في عندنا كوز، ليش بندور على الكوز اول شيء؟ ايش؟ to prevent future stroke. طيب اذا عندي ستروك انا مثلا بعد 5-6 سنين what we can do؟
ممكن نفس السؤال.
اذا ما فيش كوز nothing to do for angio. احنا الان ليش بدنا نعطيكم هالهنتاي وهالادفايس؟ لان بشوف دائما اعلانات حتى بالاردن في مصر في الهند انه احنا بنقدر نسحب الفطره بعد 10 و15 سنه الكلوت. حتى لو سحبت الكلوت البرين تيشو راح يضل ديد. فذير از نو رول فور angio. اذا لم اذا كان مسكر كله راح يضل مسكر. يعني بيجي مريض بكون رايح على فلان بحكي لي بدنا نعمل هالانجيو، بقول له ليش؟ بقول لي قلت له نو. اذا عندي ستينوسيس يس بعمل انا كارب ستنتنج، اذا عندي مشكله تبريفن طبعا فيوتشر ستروك. فبعد 4 to 6 hours من الانست اوف ذا سيمبتومز غالبا there is no intervention خاصه بالانجيو. يعطيك العافيه.
Thank you, Dr. Khalid. Next speaker would like to invite Dr. Faraz Fawaris. He's a speech pathologist at our university and he had a PhD of hearing and speech science from USA. So I'm more than welcome, Dr. Fawaris. Go ahead, please.
يسعد صباحكم يا جماعة. هلا الهدف من محاضرتي اليوم الصراحة هي brainstorming على هذه neglected area. What are the complications usually after, regardless what's the cause for the head trauma, سواء stroke, cerebrovascular accidents, or tumors, car accidents, metabolic, vascular, whatever the reason, the end up results usually is the loss of speech function. من خبرتي بال 14 سنة بالمستشفى when I get consultation for to see or examine a patient, usually the report is very minimal aphasic patient. So aphasia is more than what we see in the referral or the consultation invitation. Sometimes when we examine the patient, we find this arteria rather than aphasia. On the other hand, there is a third diagnosis, which is apraxia. So there are multiple of speech or language abnormalities associated with brain lesions. السلايد الأول اللي أنا حاب يعني أحكي عنه، وهي المحاضرة برضه حكيتها بتركيا، وكان واضح إنه بهاشكي University اللي هي one of the most pioneer universities in Turkey, still they have the same protocol. طبعا أنا بدي أزيد يعني the most causative factor is no interdisciplinary or teamwork. That's the problem. Other than that, the knowledge is there. This is my job when I came back in 2008 from the States. لما نطلع على الدماغ هون النيورولوجيكال ماب ضروري يكون بين ايدينا. طبعا في golden rule وكأن أنا I have to market it إنه 1 + 1 doesn't equal 2 in the brain. Because we have individual variations, because we have emotions, because we have different behaviors, because even among twins, we examine the twins, they do have different brains. So, يعني my experiences in life, although we have, according to the approach, the previous approach, 2 centuries back, اللي هو وقت بروكا ووقت فيرنيكي لما صنفوا الدماغ كان very primitive knowledge, because they don't have the complexity of instrumentation. The radiology, the intervention radiology just came through recent years. فهو اجتهد بروكا بال 1860 حكى انه في بروكس اريا سماها باسمه انه any patient if traumatized in this region he will lose the articulation function, which is the motor aspects of the articulators, the speech apparatus, which is very complicated starting from the lungs through the larynx, the oral cavity, nasal cavity, then the neural supply. The 5 segments in the body that just to produce one segment, one sound, or maybe one phonation. بعد ال10 سنين اجى وراء فيرنيك يحكى عن نفس كارلز فيرنيك يحكى عن sensory aphasia. طبعا still it was very primitive. بس حدد المنطقة at least اللي هي superior temporal gyrus. If you have any trauma in that region, you will lose your ability to understand speech or understand language. It sounds even more than that. بعد شيء 50-70 سنة اجى الانتاي localizationist group وحكوا انه the brain doesn't work separately in discrete relationships. It works in more of mutual relationships. So multi-regions in the brain work for the same function. We know that beyond the central sulcus back to it, this is sensory, which is the parietal lobe here, devoted for sensations. The general sensations plus the فلو بدي اجي احكي عن الباريتال لوب يعني post central sulcus هون في عندي 2 regions دائما بنواجه مشاكل فيهم which is the angular gyrus and the supramarginal gyrus. هلا هذه بتشكل most of our dictionary يعني your semantics المفردات تبعتك شو بدك تحكي طبعا in your native language first of all. Here we have to admit that there are huge differences between patients who have only one language and 2 languages. Because these margins of the angular gyrus plus the supramarginal gyrus are wide span with patients or individuals who have second language or third language endorsement. فلما يكون عندك لغة أو 2 أو 3 that means the patch is wider. So if you have one stroke pinpointed in the angular gyrus, you might lose your primary language because it was devoted for your first language. But if you have, let us say, Germany or Dutch or whatever other languages, you will not lose them. So you could switch between your own language to the second. That means topographically the brain map had been changed. So any neurosurgeon should have good history when he examines the patient or she examines the patient to collect how many, so it should be in your case history format. How many languages do you speak? How many languages do you read or write? So these are 2 areas that are significant when you consider them. Now we have inter-operative monitoring for patients who undergo any brain intervention. Either ECT or electroconvulsive therapy or whatever, or even neurosurgical intervention. We can monitor these areas if we can exclude any interference with them. The awakened craniotomy, you can talk to the patient. You can give him instructions. You can take feedback from the patient. You know what's going on because you know this cortex. It's devoted for this function. The post-central gyrus, it's general sensory area. The inferior parietal lobule here, if we consider this parietal lobule, it's the association area between what you read, what you hear, and what you touch. So we have tactile language, we have spoken language that you are hearing now, and you have some visual codes that you can read from the occipital lobe. So the interplay between these 3 cortices, which is the parietal or the occipitotemporoparietal region, is the inferior parietal lobule. Most significant is the underneath white fibers, the white matter that connects the sensory areas in the brain to the motor region. You want to speak something, you have to ideate it, you have to think about it, then to convey those neural impulses through the acute fasciculus. So any trauma, you should look at the as Dr. Mace now showed a slide, it's very globally catastrophic change to the patient. So it destroyed the cortex plus the subcortex. So all of the pathways that connect what you feel to what you produce are gone. No more brain or no more fibers. So this is a global aphasia. The patient is severely impaired. No, he cannot ideate, he cannot understand, he cannot read, he cannot even remember his remote language. Language become like garbage in the brain. You cannot decode or encode any single, even his name is lost. So the arcuate fasciculus comes from what we call the superior temporal gyrus here, which is the Wernicke's area that understand language. Actually, the understanding here should be in a triad. This is a myth that Wernicke is only responsible for receiving perceptions of language codes. It sounds that the image is better than that or even complicated than that. Usually it should consult with the dictionary in the parietal lobe. There is a dichotomous pathway. You open your dictionary, you understand the given language, then you go back to Wernicke area to understand the rhythm. Now we have just adjacent to it is the Hirschfeld's gyrus, which is the primary auditory area. Primary auditory area is responsible for decoding auditory stimuli. You know, there is a sound, like the fan of the projector here, or my voice. The role of the angular gyri and the temporal gyrus is to understand what kind of voice is this. Now, for environmental sounds, like sounds of birds or let's say cars, you understand it from the primary auditory area. That's fine. But if it comes to speech, you have to consult more of complicated routers, more complicated pathways. If I want to name just the kind of aphasias, we have more like 9 different kinds of aphasias. The patient is unable to speak, unable to understand language, but we have subdivisions. We have a differential diagnosis between them. Classically, we have motor aphasia, sensor aphasia, and the slide that Dr. Nice showed is global aphasia, which is in the trunk usually of the middle cerebral artery. It's almost occluded, okay? So the patient is left without no chance to regain any, unless, as we know, the anti-localization group support the idea that you can shift this function to the right hemisphere. The right hemisphere is not special for, is not properly devoted for language, but you can regain some residual language, like family member names, some personal stuff, but you cannot go into more complicated ones. Now, we have 3 recent diagnoses, which is the transcortical motor aphasia or sensor aphasia or the mixed aphasias. Again, as we mentioned, we have the vascular supply through the vertebral artery, through the anterior cerebral artery, and the middle cerebral artery. When you have the connection at the watershed region, any stroke in that branches, the distal branches of those main arteries, it creates what's called transcortical motor aphasia. Now we say the patient is confused. Am I able to speak or I cannot? The physician is again confused. The speech pathologist is confused because we have transient and less severe symptomatology. So when the patient comes to the emergency room, we send him back home as malingerers sometimes, as atypical stroke. So we send him back home, but this is actually bad. So you should be aware of these diagnoses: transcortical motor, transcortical sensory, and the mixed type, which is the most severe type. More than that, we have the conductive aphasia. You understand language, you can read language, but you cannot code language, you cannot respond back. So the patient, in a way or another, is mute. Okay. Actually, the lesion here is in the arcuate fasciculus. It sometimes comes with middle cerebral artery stroke, sometimes comes with the arteriosclerosis, so we should be aware of the dietary habits of the patient to prevent this type of aphasia. The last one to talk about is the primary progressive aphasia, which is not even known for many of us. It goes with aging, it goes with dementia, so the patient comes in between. Is he dementic or suffering from language processing issue? So we call it central auditory processing disorder, ending up with a result of aphasia. Now, when it comes to the motor aspects of speech, okay, we have again the most common types, the 5 or 6 different types of dysarthrias. Again, we cannot say a generic term dysarthria. We have to pinpoint the diagnosis, because the intervention and the treatment and the prevention for follow-up or for further traumas is significant. And the patient, he has the right also to regain its speech function. So it's better to go, when we say flaccid dysarthria, we are talking about lower motor neuron, some of the cranial nerves dysarthrias. If we are talking about spastic, it's a brain stem, usually infarction. Hypokinetic, it's classically typical with motor neuron disease with movement disorders, mainly Parkinson. Hyperkinetic, it's in the basal ganglia, again, it's a brainstem infarction. So we should be aware of at least the site of lesion and how to revascularize. Ataxic, it's the involvement here is more with the cerebellum and any region in the brain that contact or in contact with the cerebellum. Again, the cerebellum, sometimes we have disregard to it. We say it's okay, very miniature structure for speech function is not that necessary, or for swallowing function, or even for phonation function. No, we have 3 major subdivisions for the cerebellum. Although it's teeny tiny compared to the brain sophistication, but we have at least one of them is the vestibulocerebellum, your balance, your speech balance, your swallowing balance, your driving and walking balance. So you should be aware of, at least for neurosurgeons, for the posterior cranial fossa tumors, how to resect, okay, how to intervene with the patient, and how to be aware of the complications. One of them is the most common in kids and children, is the posterior cranial fossa mutism syndrome. Now, will this child be mute forever, or will he regain his language function? And I had been consulted many times in this hospital for those kids. I know the pathway. I know they might be mute for 3 weeks, but in the 4th week, this is spontaneous. Sometimes it takes 6 months. It depends on the infra-language structure for the child. Pregnancy issues, delivery issues, post-delivery issues, how the child develops his behavior. So from this pinpointed nice history, you can know what's the pathway or the chance for prognosis for the child. And the most important thing is stimulation. You have to stimulate the brain as early as possible and as densely as you can. The mixed type, usually it's a complication between spastic type and any one of these subtypes. Apraxia. In this slide, I think we should be aware of the supplementary motor area here, which is the prefrontal loop, or just in front of the primary motor area. This is a regulator for our intentions, our movement. So without programming, without planning for any movement, spoken language or written language, or your motor drive, okay, should be reorganized with the, let's say, interference or consultation with the cerebellum. Rate, range, speed, balance of movement should be regulated from the cerebellum with the interplayer, the second interplayer, which is the supplementary motor area. In this region, if we have, let's say, watershed region, just in the miniature vessel there, you end up with inability to set up your thoughts. You cannot organize your speech articulator, so you start to confuse your language. You prefer not to talk because you are embarrassed. Okay? So the supplementary motor region is the organizer for, not for speech function. You should consider all motor domains. We have speech apraxia, at the level of the lower prefrontal and frontal, because the face, the tongue, the arm, all of these are located here. We have oral apraxia. The patient can talk, the patient can speak, the patient can communicate, but if you want to, let's say, lick his lips, if you want to do any extra movement which is oral for, let's say, brushing the teeth, he cannot devote also, he cannot execute that cortical function. Why? Because it's only for oral agility. The speech organs or the articulators are missing. Sometimes they end up with sleep apnea. Why? Because he had oral apraxia. It's not because he had respiratory distress or anything related to the pulmonary system. So you should think about MRI first, then check the mechanical aspects of respiration or speech. Limb apraxia. We go into many troubles during driving or during writing because we have confusion between which is left or right. And I believe there is a colleague here who is going to present about lateralization in the brain. Are you right-handed or left-handed? Are you ambidextrous? You have the skills to use both languages, both hands simultaneously with the same speed, the same complexity level. The other thing to think about in terms of lateralization or interhemispheric consultation through the corpus callosum is we do not focus only on hand. We have handedness, we have leg domain, we have eyedness, we have earedness. So we have 4 functions to determine if this patient is right hemisphere balanced or left hemisphere. 1 minute, 3 minutes. So. And the most significant one is swallowing apraxia. Here the patient is marvelous in all other domains except for the eating function. They go through choking, they go through aspiration moments because they cannot regulate the timing of bolus management. So when they put something in their mouth, they choke. Why? Because the timing for, let us say, velopharynx to shut down the nasal to the nasal cavity is impaired. Sometimes it ends up with nasal regage, sometimes with aspiration. It depends on the position, the posture of the patient, and the speed of eating. So we should be aware of swallowing apraxia. Usually when they hold the cup, they put the liquid on their chest rather than in their mouth because they don't have adequate metering between the cup and the face, or the lips at least. Agnosias, you see the object, you hear the object, you touch the object, but you have misperception to it. Is it a psychiatric disorder or a neurological disorder? Actually in between, it's confusing. It's a territory that is, but the different types of agnosias, according to where you are, okay, in the brain, as the brain map. Autotopagnosia usually do not recognize body parts, although you can touch them. More specific one is the finger agnosia. You cannot, most likely here we are talking about the parietal lobe. So it's impairment or pathologist of the parietal lobe. Prosopagnosia, you can recognize the sound, you can orient yourself to the person from head and below, but you cannot, you are confused with the face. Males, females, you cannot recognize them. We have color agnosias, we have time agnosias, and most of us, disregard time these days. Symptom agnosias, sometimes you understand one discrete item of the body, but not the whole picture of the body, which is vice versa. We usually, if I want to simplify something for you, I put it all together, not as a sequence or a piece. Agnostic alexia, even we cannot understand that this is arithmetic information. يعني الديكشنري تبع القاموس اللغوي كله هذا اختفى، يعني بمعنى الانجولار جايرس، السوبر مارجنال جايرس، بصير شوف الكتابه زي هذه زي كانها it's like a topography for a mountain or something. سيمانتيك اجنوزي لا، بصير في كلمات محدده المريض ببطل يفهمها. اوكي، طبعا هذه برضه بتمشي مع الديمنشيا او السينيتي او طبعا هون في عندنا شويه كلينيكال فينيتس على هايدروسيفالوس كيف تفكر باتليست بالبرين ستيم، لانه البرين ستيم فيها كورتيكو سباينال كورتيكو فالفر تراكس كثير بتنعش يعني او لها دور كبير السبيتش كوندكشن، فمنها الهانتنجتون كوريا، منها الامراض اللي هي الCNS طبعا وغيرها. يعني في كثير من الموفمنت ديس اوردرز بتظهر مثلا هذول كلهم victims after death. acute meningitis بصير في brain edema, you lose all of the طبعا general brain functions plus language. stroke لما نقول احنا stroke هذا ما يتبقى من الدماغ من MCA او يعني حتى هذا مش تيبيكال، مش ضايل غير تقريبا inferior temporal bone، شوي من الثالاموس والبرين ستيم، وبس بشكل عام كل الموداليتيز فور لانجوج سواء كانت decoding, encoding او transportation system او dictionary system كله lost. lacunar infarction هو احنا بنفكر على الانتيريور corticospinal tracts in 10% of our need for speech function. pontine hemorrhage طبعا fatal زي ما انتم شايفين المريض بيكون هون عند السيربيلم على الفورث ventricle، كل هذا الحكي بيكون affecting الدورسال column medial meniscal tracts، فبالتالي المريض هون طبعا قبل الوفاه بدك تفكر بالتاتش proprioceptions، كل هذه بتكون lost plus other formulas. middle cerebral artery الدكتوره ميس حكت عنهم والدكتور خالد برضه ذكرهم. البرين edema due to car accidents, concussions برضه fatal. contusion laceration في the lobe او غيره. يعني اصابات عديده زي ما ذكرنا vascular tumor, benign tumor growth, slow growing virus، كل هذا الحكي بأثر على البرين فانكشن، فبالتالي we should be aware ونقدر نصنف المريض عشان نقدر نعمل more prevention، نشوف البيهيفيرز تبع المريض، نشوف البروتوتايب personal prototype مين هو هذا المريض. sometimes بيجي typical classical middle cerebral artery والمريض ماشي no hemiplegia، ومرات بيجي مريض لكن الانفاركشن المريض بيجي bedridden، فبالتالي البرين يعطيكم العافيه.
Thank you for very kind and sophisticated subject actually. We can take one question. Any questions? Yes.
في نوع من انواع الميوتيزم اسمه selective mutism.
نوع من انواع
الميوتيزم.
Yes.
Selective mutism.
نعم.
Oftentimes it comes with high functioning autism like Asperger's syndrome. So is there a somatopsychic cause?
هلا الصراحه الالكتيف ميوتيزم او السلكتيف ميوتيزم اهم شيء نعمل ديفرنشال دايجنوستس بينه وبين الموتور ميوتيزم. في ضوء عندك لانه زملاء ثاني من غير ضوء ولا مع ضوء؟ انا شايف حالي بعد
بدون ضوء.
من غير ضوء كانت المحاضره الاولى مقبول. الدرجه الاولى الهيستوري تيكينج والكلينيكال اكزامينيشن. اتس مور اول شيء مور كومن اذا نحكي عن الكتيف ميوتيزم among females لازم نعرف السايكولوجي لهم. يعني المفروض يكون البيدياتريشن هون اوير، البيدياتريك سايكاتريك دكتور المفروض يكون برضه اوير بالحاله. والميديكال سبيش باثولوجي انا ميديكال لكن هم هذول بيجوا عند الامبريلا او ديفلوبمنتال. لازم يكون عارف السايكولوجي للطفل، الفاميلي ستراكشر، الفاميلي ماب، شو المشاكل اللي جوا العائله، لانه موست لايكلي هذا هو الويبون انه يضغط الطفل على الاهل فيه، تقريبا زي الكونفيرجن الافوني عند الفيميلز، برضه ستيل we are talking about female oriented disorders. وفيري stubborn المشكله، يعني بيدفع الطفل الثمن 15 20 سنه من عمره until she can regain her speech control. وبرضه بكون حتى في مشاكل اثناء الدراسه فيما بعد. الان الموتور ميوتيزم لا، احنا هون نحكي عن برين ستيم، نحكي عن البيري فنتريكولار اريا، نحكي عن البيري اكودكتال جراي ماتر بالريتيكولار فورميشن سيستم. هذه something different، يعني في MRI في ليجن معناها this is motor mutism. الشيء فري طبعا قبل ما اعمل MRI حتى بشوف الفاميلي ستراكشر، بقعد مع الطفل بحلله. So it's most likely psycho-emotional يعني psychosomatic rather than العكس. يعطيكم العافيه.
شكرا دكتور، يعطيك الف عافيه. فقره الشهادات. طيب مرحلة التكريم الآن والشكر اللي أعطوا المحاضرات. دكتورة سماح أبو رحمة تفضلي. كيف عندك دكتورة؟ دكتور خالد طلع عنده حالة. دكتور فراس تفضل. مشكور دكتور.
والزملاء طبعا اكيد استفادوا من بعض اليوم. ان شاء الله تكون بس ما كان في طموح للدكتور خالد نشكل ستروك تيم بعد فتره، يعني انا جيت اليوم انا كليه علوم طبيه مش طب، لكن definitely we are one of the active members في الستروك تيم او الافيزيا مثلا البروتوكول كيف نتعامل مع المريض. هذه المحاضره يعني مسجله انا كان stand on more touch areas.
نحاول نعمل تطوير معين.
شكرا لك.
مشكور دكتور فراس. الله يعطيك العافية. دكتورة ميس الشواورة. يعطيك العافية دكتورة. دكتور أحمد ياسين.
يعطيكم العافية جميعا. هذا الكفر بريك. Thank you very much.